Hello everybody, my name is Shmulik Banai, with me Dr. Koenigstein Maayan, and we are going to perform a reducer implantation procedure today. We started already with puncturing the jugular vein, the right jugular vein. We did the puncture ultrasound guided, and we have now a 9 French sheet in the jugular vein, and we are ready to start. On the table for the beginning of the procedure, we have a long J wire, and we have a multi-purpose diagnostic 6 French multi-purpose catheter with a lower syringe with saline. The first stage will be to go into the right atrium and measure pressure in the right atrium. So we go with the multi-purpose without a wire into the right atrium, and we measure the pressure. The mean pressure in the right atrium should be 15 or less. 0, please. Okay. Pressure. Okay. So the mean pressure in the right atrium is very low. It's 1. So we are fine. We'll take a syringe with contrast, pure contrast, and Maayan will try to engage the corni sinus. The way she engages the corni sinus is extending her hands and trying to go from 11 o'clock to 5 o'clock, giving a little test of contrast to look for the ostium of the corni sinus. As soon as she detects the ostium of the corni sinus, she will go in with a catheter without a wire and try to go up in the corni sinus, overcoming usually 2 valves. תל מי עוד איזה ניסיון השניים? יותר גבוה? אוקיי, נפסיק. עכשיו ברגע שתהיי בפנים, אז תהיי ספינה. תנסי לבוא מלמעלה, רק נמוך מלמעלה. אוקיי, אוקיי, עכשיו תעשי. הנה, תני טסט. So here is the corni sinus. She goes in with a multi-purpose without a wire. If we are stuck in a valve, we do not push. We never push. We just take, we wait, we take our time, we rotate the multi-purpose, and the valve will open and the catheter will jump in. So now we will take an injection, an angiography of the corni sinus. Before we take any injection in the corni sinus, we take a little test just to check that we are not, the tip of the multi-purpose is not in a small branch. And I think you are in a small branch, so go back a little bit. You don't want to inject when you are in a small branch. Okay. Here you're fine, take an injection. Angio. Okay. That's a nice corni sinus. What we'll do now, we will take the J wire and try to take it up to the great cardiac vein and advance the catheter to the great cardiac vein, and we will take another injection. Okay, the wire goes to the great cardiac vein. I will hold the wire and you try to advance the catheter into the great cardiac vein as deep as we can. Okay, that's fine. We will check again that we are not, the tip is not in a small branch, and we will take another injection. Okay. That's all. Sure. Here's the camera. Okay, we can see the shape of the coronary sinus when we are at LAO 30. David, please perform a QCA. The diameter of the coronary sinus at the bottom at 6 o'clock is quite wide. The place to implant the reducer is slightly deeper. We'll either do it on the vertebra or a little bit above, proximal to the branches that we see that goes off to the marginal area. Okay, so we perform the QCA, and according to the QCA, the diameter of the coronary sinus at the site of implantation is between 8 and 10 millimeters, which is fine. We will implant the reducer right at the vertebra that you see at the middle of the coronary sinus. So this vertebra will be our bony marker. We will implant the reducer proximal to the site that we were able to see a branch draining the marginal artery area. Okay, so the next step, since we decide to go ahead and implant the reducer, we will give heparin to the patient. And what we will do now is we will exchange the multi-purpose catheter with the long J wire. So Mayan will get the long J wire all the way in the coronary sinus. And we will take the multi-purpose out. So the wire is going in, multi-purpose is going out. Heparin was given. Okay. And we keep the wire in place. And I keep the multi-purpose, I flush it. And I keep it in the water as we will need it very soon. Okay, now we will open the rest of the equipment we will need. Let me have the guiding catheter. We will use today the Acuity guiding catheter, which is a dedicated catheter for coronary sinus. This is the Acuity catheter with a special shape. What I do to prepare it, I flush it in and out. And very importantly, we crack the one-way valve with this green dilator we have that comes with the Acuity. This is important because you don't want too much friction when you insert the reducer into the valve of the guiding catheter. It might move the reducer on the balloon. So we crack the valve first, and then the rest of what's on this tray, we don't need it. Now we will open the reducer. Okay, this is the reducer. It comes covered with a plastic tube which we take away, or we throw away. Also, the reducer comes with a metal membrane that we throw away and a plastic cover protective sheath that we pull out. Okay, now I check that the reducer is well located between the most distal and the middle marker. We have additional marker very proximally to which we will draw the guiding catheter. So the reducer is right in the proper place between the markers. I will flush the reducer and put it to rest aside until we will need it. Now I need an indiflator, please. We take an indiflator with a stopcock at the end. We will need this stopcock, it's very important. And the way to fill the indiflator is with 20% contrast and 80% saline. So I take with a 20 ml syringe, 2 ml of contrast only, fill it to 10 ml saline, and suck it all into the indiflator. So now I have in the indiflator solution of 20% contrast and 80% saline. With a stopcock at the end, we'll put it aside too. We'll need it later. The next stage is to take the multipurpose catheter, which is now flushed, put it inside the guiding catheter. We will use a telescope or a mother and child technique. So the multipurpose is much longer than the guiding catheter. It extends from the tip of the guiding catheter. And what Maayan will do now is put the multipurpose on the wire, get the multipurpose into the coronary sinus as deep as she can, and then we'll hold the wire and the multipurpose and insert the guiding catheter on top of the multipurpose, mother and child. So if you look at my hand now here, I have the wire, I have the wire, I have the multipurpose, I hold the wire, I give some tension on the wire. Okay, stop. Take a seat. What you see here is that the wire in the right atrium is making a little belly laterally. This means that you have too much tension, inward tension on the wire. So what I need to do, you need to do every time you see this little belly in the right atrium is to pull back on the wire. Pardon me? This is the way it has to be, without the belly in the right atrium. Okay, go ahead. So the multipurpose is coming in on the wire. I put some tension on the wire so we will not have any belly. Okay, the wire is going in all the way. There is some belly, so we pull back. Pull back. Okay, that's good. Now, stop. I hold now the multipurpose and the wire. Tell me. I hold the multipurpose and the wire, and now she insert the guiding mother and child technique. Stop. Enough, enough. Okay. So now the tip of the guiding catheter is deeper than the site we want to implant. This is fine. What we will do now, we will take the multipurpose out, leave the wire and the guiding in. Understand? So multipurpose coming out, wire stays in, guiding catheter stays in. There you go. Okay. So the multipurpose is out now. Okay. Hold the wire. Again, we will need the multipurpose at the end, so I flush it and keep it in the water. So now we are ready for implantation. The guiding is in place. The tip of the guiding is further, deeper to the side that we want to implant. The wire is in, so we will take the reducer and put it over the wire. Now, before we go on, as I mentioned previously, one of the most important issues in the reducer implantation is that we must oversize the reducer in the coronary sinus. Oversizing is important because it prevents migration, and the injury that is caused to the vessel wall initiates a process of injury-induced tissue growth, and the tissue growth will cover the struts and the gaps between the struts, and tissue growth and coverage of the reducer will establish the pressure gradient across it. So in order to verify that we are oversizing sufficiently, I will put here on the side port of the guiding a syringe with contrast. And when the reducer will be fully inflated, we will inject some contrast through the guiding catheter to make sure that no contrast is going around the balloon and that we are sufficiently oversized. So now Marianne will take the reducer, put it over the wire, and get the reducer to the level of the right atrium and then stop. So I'm waiting for the wire at the other end of the delivery system of the reducer. Show me fluoro, please. Okay, so the wire is a little back. I'll extend the wire in. That's fine. And I'm giving some tension on the wire. I'm holding the wire with tension, and the reducer is coming in. Stop. Take a cine. When we bring the reducer inside the guiding catheter, it is very important to stop for a second in the right atrium, take a cine, and make sure that the reducer is well located between the marker and it hasn't moved on the balloon. In case the reducer has moved on the balloon, you take out the guiding plus the reducer as one unit and leave the wire in and start over again. So in our case, the reducer is well located between the marker, and what Marianne will do now is go in with the reducer to the site we want to implant. Everything is done inside the guiding catheter. Go ahead. Go ahead. Very good. Okay. So we are right at the location where we want to implant. The wire is in place. I'm going to connect the indiflator. And we are going to draw the guiding catheter in one motion to the most proximal marker, leaving the reducer in place. Go ahead. Okay, guiding catheter is back, reducer is free, and we are going to inflate to 4 atmospheres. So we are inflating. What happens is this is a very big balloon, so I'm inflating, the needle comes down, I'm inflating to 4 atmospheres until the needle is not moving and it's exactly on 4 atmospheres. When it is stable, we will take an injection of contrast through the guiding to make sure that we are sufficiently oversized. Why don't you do it, Maya? Shoot. Okay, we are oversized, but we can go even higher. I'll go to 5 atmospheres. Take another injection out. Okay, we'll do it again. That's fine. Okay, see, no contrast is going around the balloon. We are at 5 atmospheres. And the needle is steady, so I will deflate now the balloon. Okay, deflation. With deflation, we take our time because getting out the balloon, the deflated balloon with the wings, is probably the most difficult part of the procedure. Taking out the deflated balloon with the wings through the narrow neck of the reducer is an important task, and there is a little trick how to do it without moving the reducer with this bulky balloon. So first thing that we do is we deflate 3 times. So after first deflation, I empty the indiflator. That's why I need this 3-way stopcock. I completely empty the indiflator and deflate again, and we will do it 3 times. Meanwhile, what we will do also is flush the guiding catheter with saline to get rid of the sticky contrast which is in the guiding. It will make it easier to pull back the bulky balloon. So Mayan is flushing the shield, so leave it there. We will deflate again. Again empty completely the indiflator and doing another suction. Stine, please, so we'll see okay, we can see the reducer exactly where we want to implant it on this vertebra. And now we are ready to take the balloon out. We'll try to do it without moving the reducer and without losing the wire. Very important not to lose the wire. Okay, so we don't need the indiflator anymore. What I will do, I'll lock it towards the balloon, towards the patient, and get rid of the indiflator. We have the wire, very important to keep the wire in place. And what we will do is Mayan in her right hand will pull out, with her right hand, will pull out the balloon, and with her left hand will allow the guiding catheter to go in, and the tip of the guiding catheter will go all the way in to the narrow center of the reducer. The guiding catheter, the tip of the guiding catheter, will back up the reducer, while Mayan is pulling out the balloon into the guiding catheter. So her task is with her right hand to pull out the balloon, and with her left hand to allow the guiding to go in and back up the center of the reducer. My task is to keep the wire in place so we don't lose the wire, just in case there is a migration of the reducer. If we have the wire in, we'll be able to snare it out easier. So let's go ahead. Better? Yes. Okay, I'll call the scene. Guiding going in. Okay, okay. Look at my hands now. Okay. I'm taking over here. I'm pulling out the balloon and keeping the wire in place. And I'm keeping the guiding catheter away from the reducer by pushing a little bit on the wire. So the balloon is out. This is the balloon. We don't need it anymore. Take a scene, please. We'll see that the reducer is in place. Okay. Now, what we will do for the final stage, we'll take again the multipurpose, put it over the wire, go into the coronary sinus through the center of the reducer, and we will take our final shot with the multipurpose from deep in the coronary sinus. So I'm waiting for the wire here. When I get the wire, I put some tension on the wire for my hand to go in. She goes in with the multipurpose through the reducer, up, enough, thank you. I'm taking the wire out, Hine. Pulling the wire out. Okay, now we have the multipurpose, inside, deep in the coronary sinus. Again, before taking any injection, I remind you again, take a little test just to make sure that you're not, the tip of the multipurpose is not in a small branch. Go back a little bit. Okay, now take the final shot. Very nice. So we see the coronary sinus exactly where we wanted it. It's oversized on both ends, and it's located proximally to the branch that drained the marginal branch. This patient has a CTO of the circumflex artery. Therefore, it was very important to implant the reducer proximal to the draining branches of the circumflex territory. Now, you can see clearly that contrast is flowing through the struts around the narrowing. You can see some narrowing. You can see nice oversizing. but the final results will take about 6 weeks to 8 weeks from now, when the oversizing on both ends will initiate the process of tissue growth. The tissue that will grow will cover the gaps between the struts, and then we will have the final establishment of the pressure gradient across the reducer. So I'm very happy with the results. What Maayan will do now is, under Cine, we'll pull out everything, and we will see that the reducer is located properly, hasn't moved nicely. So the procedure is done, a relatively simple procedure. We will leave the sheath, the introducer sheath, in the neck for about an hour and a half, and we will take it out while the patient is partially seated, so the pressure in the vein is lower. We'll press on it for 3 to 5 minutes, and that's it. The patient will stay tonight in the cardiology department. It will go home tomorrow morning. All patients are loaded with aspirin and Plavix prior to the procedure, and we continue dual antiplatelet therapy for 6 months. For patients who are on anticoagulation or NOAC, we give double therapy of the anticoagulant and Plavix. We invite the patients back to our outpatient clinic for a follow-up at 1 month, 3 months, and 6 months, and then yearly. And usually, as I said, we start to see the improvement in symptoms after a month and a half and up to 3 months. There are some patients who improve immediately. These are the patients in which we implant the reducer directly over a valve in the coronary sinus. Then we see the narrowing immediately. Otherwise, it takes between 6 weeks to 3 months until the pressure gradient is established and we see marked improvement in symptoms. Okay, thank you, Maayan. Thank you all.